In this module, we'll look at a practical example of whole brain MVPA in action from our research. The topic here is pain biomarkers. So pain is an important health problem, and it's usually measured using self-reports. So our goal here is to define a robust and meaningful biomarker for physical pain, at least in an acute experimental setting, that can augment pain report as an outcome measure and help us understand the basis for pain in more detail. So can't we just ask people how they feel? Well, this is a typical pain rating scale. You'll get something like this in a hospital or clinic, and real clinical decisions are made based on your response to this scale. And so, of course, the only way to really assess pain is to ask people how they feel. But self-reports are very complex. They're influenced by a number of factors. So one of my favorite examples was this study that looked at a number of people with chronic pain complaints. And they asked them how often they experienced a variety of symptoms on a scale of twice a month or less to several times a day. And 65% of the patients reported symptoms more than twice a month. In another group, the researchers just changed the scale anchor points to never to more than twice a month. Now, only 39% of the sample reported frequent symptoms. So that would be a pretty big difference in any clinical trial, but it's all about just how they presented the scale to the participants. So there are similar effects for life success and happiness and other kinds of self-reported decisions. So pain reports are important, but they're not the end of the story. And this is a quote from a patient who was suffering from pain. She had a debilitating condition in her kidneys that essentially just wasn't believed when she went to the emergency room, and she almost died. She says, "There's nothing more horrific than a doctor looking you in the eye and saying there's nothing wrong with you." Another reason it might be important to measure pain objectively in the brain is because of this man, Philip Pitso, in his story. He wrote an op-ed piece in the New England Journal of Medicine a few years ago where he described his long experience with pain first. He's the former dean of Stanford Medical School and also the chairman of this Institute of Medicine report on relieving pain in America from 2011. So virtually nobody knows more about pain than Philip Pitso. However, he had an experience where he was on the way somewhere and traveling. He got the bag off the conveyor belt. All of a sudden he feels pain in his butt. It doesn't go away. And he ended up going through a round from doctor to doctor trying to figure out what was wrong. And eventually they did find something physical, a nerve problem that they were able to fix. But along the way, people started wondering whether he was getting depressed, whether he was happy with his job, and whether it was really maybe all in his head. So brain imaging can help us to understand what the basis is of this. There are many other applications of objective measures. It can help us to understand how interventions work. It can help us make better legal decisions, ultimately. It can help with medical applications. It can help us empathize and understand with people in pain, which plays a big role in helping to resolve the health disparities that still plague our country. So there are many examples of this in the popular press and in the literature. But it turns out that if you are a woman or an ethnic minority, then you need to report more pain to get the same amount of treatment. So in this NIH infographic, it has some key references documenting that if you compare black people to white people in pain, if you're black, then you're more likely to get referred for substance abuse assessment, fewer referrals to a pain specialist, more drug urine tests. And during visits to the emergency room, who gets the opioids? Well, people of the highest socioeconomic status. What this tells me is in part that people are not believing people when they come in pain, and it's really not a level playing field. And it's in part because people interpret subjective reports of pain very differently depending on who's doing the reporting. One other application of biomarkers is in making decisions in clinical trials. So Richard Hargreaves did an interesting analysis, and he showed that the use of biomarkers in clinical trials, in early phase 2 trials, increased the savings by 180%, or a realized return on investment of 180%, even when you factor in the money that's spent on developing the biomarkers.
Martin! Hey, I want one last chance to teach them.
Technical stuff.
So to illustrate, mathematically this is what we want to do. We have brain activation in the vector x. So x is here, let's say, a v-dimensional vector, where v can be all the voxels of the brain. We want to develop a biomarker, w, which also has the same dimensions, so that we could take the dot product of the biomarker and the brain activation to get a biomarker response. So let's show how we can do this in a practical example. So we're going to develop a biomarker using data from a study of thermal pain of 20 subjects. Statistical learning techniques are going to be used to identify spatial patterns of fMRI activity that accurately and specifically predict physical pain at the individual level. So the development of this method entails the following steps that we walked through in the previous modules. First, we have to define the appropriate features. Next, we have to choose a classifier. Then we want to train and test the classifier. And finally, we need to validate the results on new data sets. Can you sit down? So here's an example of the data. So 20 participants received a series of thermal stimulations for 12 trials at each of 4 different intensity levels. It started off with innocuous warmth and then 3 levels of increasingly painful thermal pain. Each trial consisted of separate periods of anticipation, thermal pain, and pain recall, and the outcome measure was a trial-specific pain rating reported on a continuous scale. So the process of performing MVPA on this data follows following steps. First, we define which features we want to use in the classes, then we perform feature selection, then we choose a classifier, then we train and test the classifier, and then finally we examine the results. So as feature selection, we chose voxels within pain-related brain regions based on prior literature. So we performed a meta-analysis of 224 previous studies to select around 16,000 voxels in the brain to use in the analysis. Time courses immediately following the end of heat application were included in the analysis. So what we did is we averaged the activity at each temperature for each participant over a 14-second post-stimulus window. At each of the temperature, we obtained 12 maps and 12 responses for each of the subjects. Subsequently, the data were averaged over repeated trials at each intensity level. So here we averaged the 12 repetitions at each temperature for each participant and obtained 4 unique maps per subject. Similarly, we obtained an average pain response for each participant for each condition. So at the end of the day, we had 4 maps and 4 responses for each of the 20 subjects. And this was our input data to our MVPA analysis. So as a classifier, we tried out lots of different methods. We used a lasso PCR, or a lasso principal component regression, but other classifier techniques gave comparable results. For training and testing purposes, we use leave one subject out cross-validation. And here's the weight map that we got, and we call this the MPS prior. So this is the pain predictive biomarker pattern obtained using our technique. Now, using this biomarker pattern, we can take brain activation under different stimuli and take the dot product and predict the biomarker response. Here's an example of the cross-validated prediction of pain. So here, basically what we did is leave one out prediction, and so we trained the classifier on 19 subjects and then tried to predict the 20th subject, and we did this for each of the subjects. And as you see, there's a high correlation between the predicted pain report and the actual pain report by the subject. And so the correlation here was about 0.77. We next want to see how specific the biomarker was to pain. So we compared it to other affective events, such as anticipation and pain recall. But here, the biomarker response didn't change as the intensity level changed. So it seems like the biomarker is more sensitive to the physical heat here. Next, we look at data from 30 participants from a different study, which received a series of 75 thermal stimulations across 6 different temperatures. After each stimulus, participants were asked to rate whether or not the stimulus was painful or not. If they said it was non-painful, intensity was rated on a 100-point scale ranging from no sensation at all to very warm but not yet painful. If they had rated it as painful, intensity was rated on a 100-point scale ranging from no pain to worst imaginable pain. So putting this together, basically pain was reported on a 200-point scale from non-painful to worst imaginable pain. So here's an example of the biomarker response by condition. So here there are 6 different temperature levels, and as the temperatures increase, the biomarker response increases in this quadratic fashion. Now, here's another interesting plot which shows the response by reported intensity. So remember, the intensity was reported on a scale from 0 to 200. Where between 0 and 100 it was non-painful, and from 100 to 200 it was painful. So here what you see is that the slope changes once we go from non-painful to painful. So the slope is slowly increasing between 0 and 100, and then more rapidly increasing as we go from 100 to 200. So interestingly, it seems like the biomarker is picking up more on when the intensity is actually deemed to be painful.